Myself Dr. Abhinami, second year postgraduate from Madras Medical College. I would like to thank my Chief Professor Singar Vadivel sir and my Assistant Professor Dr. Chaudhary sir for giving me this opportunity. So I move on to my presentation on knee arthrodesis by Lizarov, a case series. Knee arthrodesis is a widely accepted surgical salvage procedure. The goal is to achieve a stable and painless knee, and it is the best choice for patients with extensive bone loss and recurring infections. So indications of knee arthrodesis with extensive bone loss, recurring infections with highly virulent microorganisms, non-salvageable prosthetic joint infection, Charcot knee joint. And the various methods of knee arthrodesis are plating, intramedullary nailing, and external fixation with Lizarov or Chaudhary compression device. So why not plating? Plating can offer rigidity but not compression during weight bearing, not recommended in knees with acute infection and difficulties with wound closure and risk of fracture at plate margin. Why not intramedullary nailing? Because of chance of dissemination of infection, nail migration or breakage, fracture of distal tibia, and significant blood loss and chances of fat embolism, poor rotational control over arthrodesis site, and is difficult to remove. So moving on to my case series, why we choose to do Lizarov. So the first case is a 32-year-old female with complaints of pain and swelling of right knee and difficulty walking for 3 months. She had gone to a private hospital where she was diagnosed with a tuberculous arthritis of the right knee. She had underwent arthroscopic wash twice, arthroscopic wash followed by an arthrotomy and joint lavage twice, and she was started on ATD. But patient continued to have persistent pain and difficulty to walk independently. So patient came to us for further management. This is a preoperative X-ray showing articular surface erosions and thickened synovium. So this is the intraoperative finding where the femoral condyles show eroded articular cartilage and there was plenty of unhealthy granulation tissue which was excised. So this is an immediate post-operative X-ray. We have constructed a Lizarov ring with 2 tibial rings and 2 femoral rings connected by hinges. And we kept in mind the optimal joint position of knee arthrodesis with 5 to 8 degrees of valgus and 10 to 15 degree of flexion and 0 to 10 degree external rotation. And the shortening of limb actually helps the patient in clearing the ground while walking. So on discharge, she was started on immediate weight bearing on second post-operative day, and on discharge she was started on crutches assisted walking, and she was advised to continue the ATD. This is a 3rd month follow-up where she was on full weight bearing and she was started to walk without support, and ATD was continued. And at the 4th month, we noticed that there was crossing of the bony trabecular, which indicates the bony fusion. So at 5 months, we had removed 2 rings and patient was ambulating without any support. And 6 months, her rings were removed and she was put on a tube slab for 3 weeks and full weight bearing was continued. This is at the end of 1 year follow-up where patient is able to walk comfortably without any pain and without any support. So we are able to provide her a painless and stable knee, and now patient is very happy to do her routine household activities. So a small gist of the case. So it's a 32-year-old female. The total time period in frame was 6 months and the follow-up period is 1 year 2 months and the fusion time was 3 months. And she has a length discrepancy of 1.5 centimeter and post-operative complication was a pin site infection, and her knee scoring was assessed by functional scoring. Technical ISOM pre-op and post-operative score has improved from 14 to 87. So second case is a 50-year-old male who have known chronic kidney disease with diabetic neuropathy, retinopathy, and he presented to us with septic arthritis. Patient has initially gone to a native bone setter where for septic arthritis they have done an IND wherein thereby cutting the medial collateral ligament. So patient came to us with the valgus opening because of the MCL loss, and he was also subjected to knee arthrodesis by Lizarov. And this is the post-operative 1 month follow-up where patient was started on weight bearing without any support. This is the 1 month follow-up. And this is our 1 year follow-up. Patient is now able to walk comfortably without any pain and support. So gist of this patient, indication for arthrodesis was septic arthritis, and time duration between last surgery is 2 months and leg length discrepancy of 1 centimeter. Weight bearing was started immediately the post-operative 2, and total time in frame 9 months, follow-up period 12 months, and fusion time was 6 months. And again he had inside infection and his functional recovery has improved. And the third case is 64-year-old male who had undergone total knee replacement 6 years back, diagnosed with prosthetic joint infection, and it was done as a staged procedure. So the first stage was an implant exit with antibiotic spacer application, and then we went on to do knee arthrodesis by Lizarov, and we kept in mind the principles. And this is the 3rd month follow-up of the patient, and 9 months we were able to achieve. We could see bony fusion achieved, and then 2 rings were removed, and then patient was mobilized without weight bearing. And this is the 2 months later without any support. Patient is able to ambulate. Sorry, the video is not playing. Yes. So the gist of this patient is a 60-year-old male with diabetes mellitus. So the leg length discrepancy is 2 centimeter and immediate weight bearing was started from also post-operative 2. Total time in frame is 12 months, follow-up period is 14 months, and fusion time was 9 months. Post-operative complication, we encountered only pin site infection. So the disadvantages of knee arthrodesis that we encounter are pin and wire infections, and there could be pin loosening, cosmetic discomfort, long treatment time, and frame maintenance. But in spite of that, Elizero is the best option because it provides a rigid fixation, pressurized at 360-degree, fixed accurately, and immediate weight bearing can be started. The fusion angle and pressure can be adjusted in the early post-operative period. It's installed far from the affected site, so minimizes dissemination of infection. Alignment correction can be done, improves the bone quality across the arthrodesis site, and suitable for patients with limb length discrepancy, and convenient to remove under local anesthesia. So the take-home message: knee arthrodesis is a widely accepted salvage procedure in achieving a painless and stable knee. It is best in patients with extensive bone loss and recurring infections, and keep in mind the ideal positioning: 5 to 8 degree of valgus, 10 to 15 degree of flexion, and minimal shortening. Thank you.
Thank you. So please cut down your content. Other thing is, this is a best paper session. It is not a didactic lecture. So you should follow that IMRAD format: introduction, methods, right? Results, discussion. Introduction, discussion should be very less. I did not see any methods section. What was the null hypothesis of the study? Like, what was the main aim of your study?
So to study the functional radiological outcome of knee arthrodesis.
So that has been described since ages. Ever since Elizero started doing arthrodesis, we know that arthrodesis gives a good outcome with the Elizero. What is the novel thing in this study? You want to differ from Elizero? You want to say that it does not give good outcome?
No, sir, it does give.
So then, what is the novelty in this study? Are you trying to recreate the wheel, or are you trying to see something new with your study?
So, like for infected cases.
For infected, it has been done. From India, it has been done. From north, east, south, everywhere you will find one paper or two. So the idea of grilling you here is to make you think of. You presented very well. All your cases were also very nice. But when you are thinking of a research presentation, come up with a hypothesis, right? Justify it in the methods, and then back it up with your results. And presenting individual, because this is not a case presentation. You should present a summary of the results. So if there were 20 people in your cohort, what was the mean pre-operative score? What was the mean post-operative score? Was it statistically significant? So we want to see that kind of thing. Otherwise you presented very good. Thank you.
Thank you.
We can have the next speaker now.
Good afternoon, faculty and dear colleagues. I'm Dr. Ramesh Govindraju from Calicut Medical College. I am presenting a case of a complex deformity correction in a pediatric patient with a metabolic disorder. We followed a staged approach and used the Elizero on the exoport fixator for correction. So I'll briefly mention the points of the metabolic bone disease. These patients have abnormalities in the bone structure, strength, and mineralization. And the case that we are dealing with was a case of rickets. So whenever we attempt to correct a deformity, we must know what the normal alignment is. We should know about the malalignment test. We should know whether the deformity is uniapical or multi-apical, about the GOA, whether the deformity is a single plane or a multi-plane deformity, and the rules of osteotomy. So my patient was a 13-year-old girl with deformities of both lower limbs since the age of 2 years. She was a case of type 2 renal tubular acidosis. And in this case, this patient, she had metabolic acidosis, phosphate loss, and compensatory hyperparathyroidism, which led to demineralization and which in turn led to the multiple deformities. So these are the clinical images preoperatively showing the coronal plane deformity, the axial or the rotational deformity, and the sagittal plane deformity. She has valgus, internal rotation, and procurvatum. These are the preoperative radiographs. So these X-rays show that the deformity on the left side is more severe than on the right, and there is a mechanical axis deviation to the lateral side bilaterally, and which is more severe on the left. So since the deformity was more severe on the left side, we plan to correct the left side first, and the main deformities were genovalgum, procurvatum, and internal rotation with shortening on the left side. So we did the malalignment test, and we discovered that there was a 24-degree valgus and 10-degree procurvatum on the tibia, and 22 degrees of valgus and 24 degrees of procurvatum on the femur. So how would we manage this patient? We need to follow the principles of deformity correction. We need to treat the metabolic problem first, improve the bone quality, so that we can achieve a successful correction. So we did the mechanical axis planning for the femur and for the tibia with the paper tracing. and the planning involved an oblique plane deformity planning using the graphical method. So we can use the eraser and the head support fixator for correcting an oblique plane deformity. So this shows the planning, the oblique plane deformity plan. This is the immediate post-op X-ray. Initially, we use the eraser of hinges to correct the deformity to a certain extent and to reduce the duration of the head support frame. And then we proceeded to apply the head support, and we did a gradual correction, especially of the rotational deformity with the head support. So this is the X-ray with the head support fixator. And after tibial deformity correction, this is the post-op X-ray. And the clinical photo showing the correction of the tibial deformity in both AP lateral views. The second stage, we proceeded with the femoral deformity correction. Similarly, we used an oblique plane deformity correction planning to correct the valgus and procavatum with the graphical method. And this shows the clinical image and the X-ray of the femur after application of the A0 frame. So, finally, after a period of 4 months for the tibia and 5 months for the femur, this is the correction that we have applied. As we can see, the mechanical axis deviation has been corrected, and upon improving the metabolic parameters and the biochemical parameters, you can see that even the opposite side, even without any corrective measures, has corrected to a certain extent. So this is the functional outcome after removal of the fixators. The patient has full range of movement and there are no obvious residual deformities. So to summarize, in multiple deformities, we must always correct the maximum deformity first, and in oblique plane deformities, we find out the GOA and we plan using the graphical method. We can use a hex support or an SUV when there are multiplanar deformities, which will ease the correction. And in severe rotational deformities, it is better not to correct it accurately. The take-home message is that it is the preoperative planning part is more important in such complex deformities. We can do either a mechanical axis planning or an anatomical axis planning, depending on the case. And the choice of implant is the surgeon's decision. We can either use an internal or an external fixator. Here we use the hex support and the laser. So, and in severe deformities, gradual correction is safer than performing an acute correction. These are my references. Thank you.
Yeah, or both blue bones.
So the rotational deformity was in the tibia.
How? No, we don't want to see the slides. Just tell how will you know whether the rotational deformity is in femur, tibia, or both places, or it could even be at the level of the ankle. Right? So how did you figure out?
So during while performing the malalignment test.
Malalignment test is for frontal and sagittal planes, right? It doesn't talk about the torsional component, and it is very important.
So clinically, when we assess the patient with the pedal of forward position, the tibia, the leg and the foot.
You should read about it. And the other question is what happens? So suppose, and everybody in the house should also read about it. So suppose there is a torsional deformity in the tibia, and you correct it at the femur. What will happen? Is it good, bad? Nothing will happen.
The correction.
Meaning, does it matter? Can you correct it anywhere?
No, sir.
What will happen?
It will be to overcorrection.
It will lead to patellar backtracking as one of the main things, right? The same thing happens if you have a poorly positioned total knee prosthesis. Okay. Any questions?
You have to follow the introduction.
So,
proper way of presenting the introduction with the results, discussion. So you need to follow that.
Okay, sir. Thank you.
My name is Dr. Pradesh, final year orthopedic resident from Balaji Medical College, Chennai. Today, a case of contaminated grade 3B compound left proximal tibia with distal one-third diaphyseal tibia fracture with impedance deformity of the foot managed with Ilizaro fixation. It's a case report. Patient is a 48-year-old female. She came with alleged history of four-wheeler RTA with four-wheeler truck, sustained injury to her left leg, and she was not able to wait on the left leg, and she also had an open wound on the left leg. Local examination: open wound of size 20 by 10 centimeter, contaminated lacerated wound over the medial aspect, anterior medial aspect of the leg was there. Anterior compartment muscles were seen. Compound fracture noted on the middle one-third of the tibia and the fibula, and toe movements were present, no vascular compromise. It's a CT3D reconstructed proximal tibia. Diagnosis: contaminated grade 3B compound left proximal tibia with distal one-third diaphyseal tibia fracture with displaced fibula shaft fracture was seen. We planned for a 3-stage procedure. Stage 1 wound debridement with knee spanning AO fixator with the tensioning of the fibula has been done. After the good granulation, flap has been generated, and after AO fixator, the post debridement there was 8 cm gap nodule was seen in the X-ray. Stage 2 Elizaro fixation plus proximal tibia fracture fixation with corticotomy, bone transport, and percutaneous tendo release has been done for the epennis correction. After a period, while docking, there was skin invagination at the docking site, and there was medial translation of the distal fragment. For the skin invagination, a transverse skin incision is made around the bone ends at the docking site. The incision is deepened down to the bone, and the soft tissues are removed from the docking site. The bone ends are freshened and compressed against each other by frame. The compression approximates the skin edges together and facilitates the closure over the bone ends. Tensional removal with fibulectomy along with the frame realignment has been done. As previously, we could see there is a translation in the distal fragment. Follow-up X-ray in 3 months. With the Elizabeth, patient is walking. Frame. This is after 4 months, the Elizabeth frame has been removed. 3 cm shortening has been noted in the tibia. Straight leg raising has been done. And follow up in 18 months. There is good union. Bone loss represents a true challenge for the orthopedic surgeon. Soft tissue loss may complicate the conditions and make reconstruction more difficult. It is important to restore a healthy soft tissue envelope for proper treatment of the complex problems. This could be done by major plastic surgery in the form of local myocutaneous flaps or the free flaps. In our case, the bone defect was 8 cm in the middle, 1/3, and the soft tissue loss was 25 by 10 cm extending from the proximal leg to the distal leg on the medial side, for which flap reconstruction was done, followed by Elizaro ring fixators were applied. Physiotherapy was started early in the post-operative period to avoid joint contractures. It involved isometric contraction of the quadriceps muscle, active and passive range of movements, and stretching exercises for the hamstring and gastrocnemius complex. Bone transport was started after a latent period of about 1 week. At the time of docking, the skin incision became incarcerated between the bone ends. This stage, the patient is taken to the theatre again where the soft tissue is removed from the docking site and the skin is fashioned to cover the bone ends. Also, there was a medial translation of the distal fragment due to the interfibular and loosened third and fourth pins. Hence, frame realignment was done and the bone ends were approximated. Bone graft was done at the time to stimulate the bone healing. The frame was removed after healing at the docking site and a full maturation of the regenerated bone. The bone results were evaluated according to the union, infection, deformity, and limb length discrepancy, while the functional results are evaluated according to the daily activities, joint stiffness, limb pain, and presence of reflex sympathetic dystrophy. 3 cm limb length discrepancy was noted. According to ASAMI, we graded the patient as a good scoring.
How did you correct the translation deformity?
So we fixed with the findings, and in the post-operative
Did
period,
you do it under anesthesia or you set up a translation coach?
so, no, we took the patient to the theatre.
Again, one more
Again,
anesthesia.
operation theatre, we took the same time only it was corrected. So there was skin invagination. The same time, even the ring was adjusted.
You could have corrected without anesthesia with the translation coach.
Okay, this is a very tough case and thank you for presenting this. You actually lost 2 chances for equinus. So the first time you put in an AO external fixator, you should have spanned the ankle. Why it went into equinus is because you let the ankle remain in whatever position. And the second time you put an Elizarov frame, you could have very well corrected. Now you see she still walks with the heel raised, isn't it?
Yes, sir.
So why did you not correct it? You could have gotten the correction. And equinus really messes up all the biomechanics of the lower limb. So if you have ever have a chance, whenever you're putting an AO fixator in a situation like this, put a drop pin in the metatarsal, make the ankle plantigrade. Even if it becomes stiff, it will be stiff in a functional position. Okay?
As in long transport, better to have
Yes.
access to the ankle.
Span the ankle in long transports.
I am presenting a paper on functional outcome of extracorporeal locking plate fixation in the treatment of open tibial fractures. Introduction. External fixators has been used as a temporary fixator or a definitive fixator for high energy traumas, especially for open fractures. Nevertheless, the most external fixators for lower extremities are very bulky and cumbersome for patients, leading to problems with sleeping as well as with dressings. Also, fixation with joint spanning external fixators may cause joint stiffness and leg muscle atrophy. Aims and objectives: to assess the functional outcome in terms of range of motion, rate of union, time of mobilization, and pitfalls following use of extracorporeal locking compression plate as an external fixator in the treatment of extra-articular compound grade 1, 2, 3A, and 3B tibial shaft fractures. The inclusion criteria is the patients were of 18 years age to 65 years with grade 1, 2, 3A, and 3B extra-articular fractures of the tibia. The exclusion criteria were intra-articular fractures, the patients with vascular compromise, pathological fractures, and trauma cases of more than 4 weeks old. The study period was between 1st August 2022 to 31st July 2023 at GSM Medical College, Kanpur, of a sample size of 15 patients with assessment done at 1 month, 3 months, 6 months, and respectively. Now, locking plates were selected according to fracture pattern and the site of tibial shaft fracture, maybe LTH plates or LCP plates or spoon plates, depending on the choice. Here are the various examples with long screws. LCP plates at a distance where the skin, where there was ample area between the skin to provide adequate space for swelling as well as wound care and mechanical stabilization. The fragments were applied with the K-wires followed by plate fixation. At least 3 to 4 bicortical screws were placed proximally as well as distally. Knee and ankle range of motion is started immediately post of day 1, and after 6 weeks, partial weight bearing was allowed. Here are the various X-rays, immediate post-op and immediate X-rays followed 1 month, 3 months, and 6 months respectively. The fractures we observed were proximal tibial fractures with most cases distal followed by middle. The fracture pattern was grade 3, grade 3B were 6 and grade 2 were 6. Now, the plate was kept ex situ for a period of 16 to 36 weeks with a mean time of 22.6 weeks. It was kept for about 4 weeks after the union, which was about roughly around 17.2 weeks. We achieved overall rate of 80% union. Yeah, the various about 17.2 weeks, there was a clinical and radiological healing. They were assessed, the patient was assessed upon OFAS as well as hospital special surgery knee rating system. Now the complications that we encountered: non-union in 3 cases, malunion in 1 case. 1 case, patient had a screw site infection, for which we did regular wound cleaning and dressing by betadine and various antibiotics were started. And 1 case of screw losing, in which case we removed the involved screw. Now discussions. There have been various studies. Weiser et al. Had about outcome of 94% with a mean union time of 21 weeks. Chinese also had Jingbens et al. Had 2014 had a 100% clinical output at 14 weeks. The present study had outcome of 80% in about 17.2 weeks, followed by rate of union about 12 to 24 weeks. Now, locking plate can be used as an external fixator with reference to conventional external fixators. The patient acceptance was higher in the locking plates, early ambulation was provided, better range of motion was provided, stability was relatively better. Disadvantages. The external locking plates require a good reduction prior to fixation due to limited manipulation that can be done after that. Compared with a standard external fixator, the cost was relatively much higher. Now here's my conclusion. Extracorporeal plating can give promising results in open tibial fractures in terms of functional and clinical outcomes with better patient acceptance. Thank you.
Very nice presentation. But one question for you. Suppose if you are a L0 surgeon, where will you use this extra skin fixation technique?
Sir, for stabilization of first we will put plate in proximal tibial fractures and then we can put L0.
This technique helps in premature removal of the ring, that is decreasing the external fixator time. Yes, we can use this. That is the only indication for your presentation. Sorry to say, but it's a trauma and not L0 related, but very well presented. Nicely that all you followed all particular presentation method.
Thank you.
Yeah, I saw you put the locking plate
Yes, sir.
at the lateral side of the tibia.
Yes, sir.
So, and many people like to put the medial side because of the irritation of the soft tissues. When you put it lateral side, how about the soft tissues?
Sir, you mostly use the lateral tibial head plate that is usually put on the lateral side. That's what we were.
You can use the medial locking plate.
Yes, sir. We have used a medial plate also.
So why not?
Thank you.
Plate is available laterally.
Yes, sir.
Types are available.
Yes, sir. But in proximal fractures we used.
Actually, to decrease the external fixator time, we usually put it on the anteromedial surface.
Yes, sir.
If you put it on lateral side, again muscle impingement, anchoring of the muscles, scarring. This will lead to decreased ankle movements.
Okay, one last question. How do you measure patient acceptance? You said it is good acceptance. How did you measure acceptance?
Sir,
That's a very valid point. If you say that acceptance is high, you should be able to quantify it.
sir, the range of motion that we assess.
No, acceptance. So you are saying patient accepts this implant better than the external fixator. How did you measure patient acceptance?
Sir, the patient,
Something to think about. If you find an answer, good. If you don't find an answer, come to me after. I'll tell you how. Thank you.
The title of my paper is a prospective study on evaluation of tibial condyle fractures treated with Irizarra external fixator. I will be the presenting author, Dr. Jaswant H.S., the main author being Dr. Harshadem Shah. Coming to introduction, the fractures of tibial plateau involve articular surface of proximal tibia. It is necessary to locate the fracture, its pattern and degree of displacement. While treating, we should take into consideration the anatomic reduction of articular surface, maintaining condylar width and restoring mechanical access. Lateral plateau fracture will be the most prominent out of the all fracture patterns, whereas the bicondylar and medial plateau fracture contribute to the rest of the plateau fractures. The mechanism of injury include a combination of valgus and axial compression, or varus injuries and axial compression or direct trauma linked to different kind of fracture patterns. These fracture patterns will be classifying according to Schatzker classification. The investigations we require are X-ray, traction films and CT scan to aid in the operation. Management methods can be override with latent screws, external fixation, CRIF with cannulated cancellous screws, minimum interval and external fixation. Coming to our study, the duration of the study is for 3 years and we included patients of over 20 years of both male and female in closed tibial plateau fractures. We excluded any patients with associated ipsilateral femur fractures, pathological fractures of tibia and patients who were lost to follow. We had a sample size of 43 patients and average age of 37.49 years and few of the patients had skin abrasions and contusions.
Now, based on the type of fracture, it was mostly of type 6 and type 5 fractures, and the major mode of injury being RDA. Ligament injury was seen in 13 patients and they were operated within the first 2 to 7 days, and all patients received prophylactic antibiotics for 48 hours after operation. The mode of treatment was the only Elizarov external fixator application in 28 patients, and 15 patients were augmented with the cannulated screws also. Bone grafting and marrow infiltration was done wherever it was necessary. During post-op management, early mobilization of knee joint and full weight bearing walking with walker within 2 weeks was encouraged in all patients, along with regular dressing of the wounds. This is the pre-op construct of the Elizarov external fixator. These are a few examples. We had a Chaudhary type 6 tibial plateau fracture. This is the clinical pictures. This is the day before removal of fixator and 2 months after fixator removal. These are the final result after 1 year and 10 months of follow-up. This is another case which had Chaudhary type 6 tibial plateau fracture. Close reduction internal fixation with Elizarov external fixator was done. This is 10 months after follow-up, which had good results. In Chaudhary type 6 tibial plateau fracture, this is the CT scan which had a lot of cognition. So, Elizarov external fixator application was done. There was a little translational deformity which was corrected later on, and this is post Elizarov fixator removal. This is another case which had Chaudhary type 5 tibial plateau fracture after Elizarov external fixator application, and this is on post-op day 5 where early demobilization was done. In our patients, pain and pin tract infections were most common, but we did not have any vascular complications, neurological complications, osteomyelitis or ankle stiffness. There is enough evidence in literature stating that there is low morbidity associated with the use of external fixation, minimal internal fixation, and that Elizarov apparatus shows good functional outcome and positive impact on patients' quality of life. In our results, fractures united at a mean of 26.6 weeks and full weight bearing was present at a mean of 14.4 weeks. We used Lysome knee scoring scale for assessment of functional outcome, and most of them fell in the range of between 75 to 90. Normal walking was seen in 32 patients, a slight limp was present in 4 patients, and 4 continued to walk with walking aids. Limitation of squatting to less than 90 degrees was seen in 4, and 35 could climb stairs normally, 3 with only slight difficulty, and 2 patients 1 step at a time. On radiological assessment, all except 2 patients had a step off of less than 4 mm, and 2 had alignment deviated by more than 5 degrees. Condylar widening was present in 12 knees and in 2 more than 6 mm. IF was used majorly for Chaudhary type 5 and type 6 fractures. Bone grafting was done wherever there was articular depression to fill the gap and also in one non-union. It is very well tolerated method for tibial condyle fractures. IF had predictable results with minimal complications. There are various studies on tibial plateau fractures, and from this we conclude that high energy tibial plateau fractures can be definitely treated with Elizarov external fixation. Treatment with this method gives good union rates and less risk of infection with minimal soft tissue damage and early mobilization. We had a few limitations in our study, such as unequal distribution of cases in each group of classification. Duration of follow-up in some severely injured cases is not so adequate that they regain their adequate function, and comparative analysis is not performed with other modalities of treatment. So the final take-home message is there is enough evidence in literature also to conclude that best treatment as of now, with least complications for these tibial condylar fractures, is by Elizarov methods using either the Elizarov apparatus and hybrid apparatus or any apparatus used to treat with Elizarov wires or any fine wire methods. So references. Thank you.
This one. How did you assess radiologically that the results are good? Did you study post ring removal radiological angles? Did you measure?
Yes, sir. We had measured
Because in some of the X-rays, the tibial slope was less.
it was like acceptable reduction after the X-ray, sir. Because of complexity of the crack. We measured the condylar widening, which we generally take as less than 5 mm, and then
What is the normal tibial slope? Because one of your X-rays.
normal tibial slope is around 10 degrees.
No. What will happen if it is 10 degrees? 10 degrees not.
posterior tibial slope.
What will happen? I'm not sure that is also important in tibial plateau.
Yes.
So you have to measure some angles and present it.
Okay.
Only functional score, maybe if you would have included radiological score also,
Nice.
that would be better.
Yes. I'll take that.
Okay, that's an excellent presentation. So when God was treating these fractures, when nothing was being done, even then patient had functional outcomes. When we were treating them with cast, even then they had good functional outcomes. But the principle of treating an intra-articular fracture is accurate anatomical reduction, right? So you cannot argue. So if 50% of your people have condylar widening, it is not really an accurate or anatomical intra-articular reduction. The extra-articular reduction you can agree, again with the caveat that Dr. Satish had told, you cannot have reversal of the tibial slope. It has to be, so some extra-articular parameters need to be within the acceptable range. The intra-articular reduction needs to be anatomic. Okay. And the other thing is, when you presented your paper very well, I just had this thing about the conclusion slide. You should only conclude with what your study has to say. So on one hand, when you are saying you don't have the enough follow-up to say whether it is good, bad, or then you should not say that it is the best method.
Only a few patients you can't do the entire follow.
So in 20 out of 2 is again, so if your sample size is less, then 2 or 3 missing follow-up is also a big number. If this was 200, then 2 would not have mattered. You start with a small sample size which is underpowered. You end up with missing of 2 or 3. And then you conclude by saying this is the best thing. Okay, we should not take too many liberties with the data. State things as they are. Okay, and we will still appreciate it. Thank you.
I acknowledge to all my professors. My topic is management of infected non-union in upper limb long bones with Elizaro ring fixated. Introduction. The incidence of non-union humerus ranges up to 15% and that of forearm ranges from 2.7 to 9.3%. The aim of our study is to study the improvement in the quality of life after management with Elizaro ring fixated, to study the radiological and clinical outcomes after treatment with Elizaro ring fixated. Coming to materials, we had 3 patients, out of which 2 patients were forearm and 2 females, and 1 case of humerus, male patient. The mean age was 39.67 years, with a mean previous surgery of 2 cases. The mean duration between incidence of trauma to the index surgery was 29 months. All the patients had staph as the infective organism, in which one was MRSA, and in 1 patient, the infection was in latent phase. Coming to methodology, it consisted of obtaining culture, debridement with irrigation, with or without spacer or bone graft, Elizaro ring fixator, plus docking, plus wound closure. The assessment tools which were used are infection markers, VAS score, DAS score, EQ5D5L, SF36. Coming to results, in our case, there was mean shortening of 2.61 centimeters. In 1 case, we used fibula strut graft with iliac graft. The mean union time was 7 months and the frame time was 8.67 months on average. Coming to VAS scoring system, the mean VAS score was 8 pre-operatively, which was reduced to 3.33 post-operatively, and the mean DAS score was 85 pre-operatively, which reduced to 31.1 post-operatively. Coming to EQ5D5L and SF36, preoperatively EQ5D5L average was 19.33, which reduced to 9, and SF36, which has a combination of so many characters, the preoperative score was 32.93, which increased to 67. That means there is improvement in the quality of life. In SF36, we included physical function, social function, emotional function. Preoperative and postoperative comparison is done. Coming to first physical function. It has the improvement from 66.67 to 78%. The emotional function has been increased from 45.33 to 68%, and social functioning has been increased from 29.17 to 71%. This is the first case. 49 years female patient, diabetic, uncontrolled sugars with non-union of both bone forearm, past history of self-fall 11 months back, with history of multiple surgeries like open rotation internal fixation with plating and the implant removal was done. In this case, we can see segmental fracture of the proximal forearm with radial neck fracture, which was stabilized with overall with plating and radial head excision. Following 3 months, patient complained of discharge, for which the implant removal was done. This is the radiograph showing bones with immediate implant removal. This is the radiograph after 3 months, and this is a radiograph after 6 months after the implant removal, for which Elizabeth ring fixator was applied. Proximally and distally, the bones were stabilized with vice at the proximal and distal radial joint, and the frame construct was increased with shunt spring. This is the construct at 3 months post-op, and this is the clinical and radiological picture at 7 months post-operatively. This is at 8 months, immediately after the frame removal. Patient has high sugar levels and discharging pus from the side, so for this reason the frame was removed. So for further we can check for this. This is the clinical picture showing the movements. This is 1 week after the removal of the frame, which was further reinforced with fiber cast. This is 1.5 months after the removal of the fiber cast, and these were the functional movements. Case 2, 45 years female patient with both bone forearm. This was the clinical picture at the presentation, which was having problems of there was ulnar tips tapered, there was gap mismatch, for which there was a requirement of further radial resection. Intraosseous membrane was released to prevent cross union, and ring fixator was applied. This is the post-op radiograph, 10 weeks, and this is the clinical picture how she is doing the work. This is the pre-op to post-op. One more case with humerus shaft fracture, overall plating, for which cement spacer was applied. Post 8 weeks, the spacer was removed and bone graft, fibula graft was applied. This is the clinical picture after 6 months of frame removal. The study was compared with the other studies. There is comparability. There is mean follow-up period is less and sample size is less. But comparingly, the DAS score, VAS score are improved when compared with the other studies, and we have included EQ55 and SF36 with other studies. Conclusion: ring fixator is a versatile tool to manage infected non-union upper limb long bones, as it provides rigid fixation, achieving compression at the fracture site and restore function at the earliest. These are the references. Thank you, sir.
In first case, there was a persistent non-union. Persistent non-union of the radius. And in second case, you didn't show the post ring removal X-rays. Okay. And yeah, okay.
What do you think is the most important outcome? So when you are looking at different outcomes, so you did a very good job, SF36, EQ5D, this, that. But what is the single most important outcome measure in a non-union?
Functional movements.
Union rate.
Unions.
You want to convert a non-union into a union. Aseptic is okay. Infected, you want to first make it aseptic and also make it union. So as I can see, and I agree with Dr. Satish here, it seems you have a 50% persistent non-union. First case definitely did not unite.
In the radial part, there is no unions. But on the ulnar part, the union is there, which was not hidden.
So do you think that is acceptable?
No, sir. The person had high sugars and pouring pus. So
it is a persistent non-union. So again, see, the problem with this problem is not with the results, it's how you present it. Don't try to mask it, don't try to present it otherwise, state it as it is. There is no shame in doing that. And your conclusion should be based. So what you are presenting are really difficult cases. It is not a problem. It could be a problem with me or Dr. Satish or any Elizabeth surgeon. But don't try to sugarcoat it with anything. This is something I would really like to change. So your conclusion should be that this is a very, very difficult group of people where we have achieved a 50% union rate, which is pretty good. Don't try to say that it is 100%, this is good, that is good, that. And functional outcome is good, but in the non-union, the principal outcome should be union. And we should be able to say it the way it is without feeling sorry for yourself. Okay, thank you. Thank you so much.
Bhatti, resident from SRMC Chennai, presenting a case report on the forearm deformity correction, hereditary multiple exostosis case. My guide is Professor Dr. P. Gopinath Menon and his team. Hereditary multiple exostosis is also known by names multiple osteochondromas, diaphyseal eclasis, or multiple cartilaginous exostosis. This is a disorder in which multiple outgrowths of cartilage cap bone are found on the skeleton, and it commonly affects the metaphyses of long bones. The prevalence is around 1 in 50,000 of population. Characteristic features of the osteochondroma are sharply demarcated bone lesions, usually pointing away from metaphysis and projecting from metaphysis, and cortical and medullary continuity with the parent bone. Clinical features: the exostosis may be sessile or pedunculated. For a diagnosis to be made, there should be 2 or more lesions which should be radiographically identified. The onset usually is early childhood or puberty. Painless. The patients come to clinical attention for cosmetic reasons. Presents with symmetrical or asymmetrical deformity. In this disease, the forearm deformity is the most common deformity noted, which is present in about 30 to 60% cases. The bowing may ensue when growth in either the radius or ulna is reduced. There is relative overgrowth of the unaffected bone. This may destabilize the radioulnar joint, leading to subluxation. Local effect of exostosis include impingement on adjacent structures such as tendons or nerves, causing pain, osteoarthritis, bursa formation, and cosmetic deformity. The indications for surgical intervention includes limb length discrepancy, deformity, pain, cosmetic reasons, malignant transformation, or osteochondromas causing vascular insufficiency. Coming to the case, this is a case report of a 9-year-old female child which presented to our OPD with pain over the right wrist region since 1 month, along with the swelling over the right wrist for 3 months, and a deformity which was slowly progressing since 6 months. On local examination, there was deformity noted over the proximal 1/3 of forearm, a 2 into 2 cm swelling over the distal forearm over ulnar aspect. There was no local warmth or tenderness. The arm at wrist was swollen free with ulnar deviation little exaggerated. There was no distal neurovascular deficit. These were the preoperative X-rays of the patient, in which we noted osteochondromas over the distal aspect of ulna and radius. The CT of the same limb was done, which showed the distal osteochondroma over the distal radius, distal ulna, and disruption of the ulnar epiphysis. These deformities are usually classified using Masada classification, which classifies them into 3 types. The type 1 is an osteochondroma formation in the ulna with bowing of radius, but there is no radial head dislocation. In type 2, there is osteochondroma in ulna with ulnar shortening plus radial head dislocation. Type 2A, the osteochondroma at the proximal metaphysis of radius is also there. In type 2B, there is no osteochondroma on the proximal part of radius. Type 3, the osteochondroma formation is only in the distal radius with shortening. This classification was further modified in Joe's classification because they found that they were not able to classify most of the cases in the Masada classification. So they added another class, type 4A and type 4B. So type 4A was exostosis in the distal portion of both ulna and radius with no radial head dislocation, and type 4B was exostosis in the distal portion of radius and ulna with radial head dislocation. The diagnosis of this case was made as a Masada type 1 hereditary multiple exostosis with right forearm deformity, and if we include the extended classification, it was Joe type 4A. This was the preoperative workup for the case, in which we measured proportional ulnar length, ulnar variance, radial bowing, carpal slip, and radioarticular angle. The operating procedure done was right forearm distal ulnar osteochondroma excision plus right ulnar corticotomy plus right ulnar lengthening with rail external fixator. These are the improv pictures. These are serial post-op X-rays, immediate post-op, then 2 weeks post-op. Then third X-ray is 4 weeks post-op, and the last X-ray is 3 months post-op. Clinically, this is the deformity picture after 3 months of treatment. The results, the parameters, we were able to achieve 1.2 cm of ulnar lengthening with decrease in proportional ulnar length. The ulnar variance also decreased by 3 mm. and radial bowing was also decreased. The radioarticular angle was decreased from 24 to 18 degrees. The discussion, the usual recommendation to address this deformity is advocated by Masada's classification, in which the problem they anticipate in growing children is the radial head dislocation. So the need for the early surgical management in these cases is the early surgical intervention may prevent dislocation of the radial head and deterioration of the forearm function and subsequent deformity and disability. Once the radial head is dislocated, surgical attempts at relocation usually are not very successful, with high rates of redislocation and poor functional outcomes. Proportional under length and radial bowing were the risk factors for radial head dislocation. This X-rays of a second patient we saw in our OPD 3 weeks back, which is a 14-year-old female child, and this was classified under JOE type 4B because the radial head is also dislocated along with the distal radius and ulnar osteocomponents. These are the references, the original published article by Masada and the modified JOE classification. Thank you.
Okay, good work. But when you are presenting in best paper sessions, try to come up with case series. Okay, because series will always score more than case reports. So my question to you is what was the length of follow-up?
So 3 months as of now, 3.5
Do you think
months.
that is adequate to say
No,
that?
sir. We need to follow up the child because she's in his growing age, and we need a monthly follow-up for now, up to 6 to 8 months, and then 6 monthly or yearly follow-up till she achieves the.
Which is why when you are presenting case reports, at least they should have a reasonable amount of follow-up for you to say that whatever treatment option you chose worked. Okay.
Okay.
Thank you.
Good afternoon, professors and my colleagues. Let me take you through a journey of 40 odd patients with younger patients with medial compartment osteoarthritis treated with hemicalothasis. So when we look at the natural history of medial compartment osteoarthritis, basically it is the virus that affects the damages the knee more, and the extent of the osteoarthritis scored by a Kellgren-Lawrence scoring system, and the virus adductor moment arm when the patient used to walk. And currently, the approach to the MCOA is mostly fatalistic. We give NSAIDs to the patient, intraarticular steroids, so you give wait for enough damage and do a TKR. Mostly the patients are reluctant to choose an osteotomy because they might have to have a procedure later on. So our goal of treatment was to realign the knee and achieve the normal axis and prevent the middle compartment osteoarthritis. So for the realigning the knee, we have different options, and especially the high tibial osteotomies. We have two main options: an immediate correction with a plate or a gradual correction with an external fixator. It can be we can use a rail external fixator or an Ilizaro. So this was the orthofix that we used for a series of cases. And the basic principles of orthofix here is gradual correction and doing an incomplete, that is a hemicalothasis, so incomplete osteotomy, and the calf is distracted by turning the CDO hinge screws. So the body is self-aligning, and since it is a hinge correction, so there is no translation also. Our methodology, we used, we were measuring the functional and the radiological outcomes of the cases and assessing them with the knee society score and the knee injury osteoarthritis outcome score. We included patients who with an age of less than 65 years old and with a range of movement above 90 degrees with a fixed version deformity less than 15 degrees and a varus deformity less than 20 degrees. And we avoided patients with post-traumatic arthritis, inflammatory arthritis, and tricompartmental arthritis as of principles of STO. We did a prospective observational study for a period of around 2 years. Follow-up is there for the study. And pre-op X-ray, these are the different X-rays we have taken, and those X-rays are shown in the follow-up examples. We took an AP and lateral view, a standing PA view with 30-degree knee flexion, that is a Rosenberg view, the valgus and the varus stress views, the 3-joint X-rays, and the patella skylight view. So this is the procedure proper. The patient was positioned on a fracture table, supine with patella facing forward by using a sandbag under the trochanter and the hip, and the leg was hanging. And the first pin was applied parallel to the joint line, 1 centimeter below it at the level of the fibula head, from the medial to the lateral, and the position was confirmed on the AP radiograph as well as the lateral radiograph by confirming that it is in the posterior part of the condyle. The second pin, and after confirming the first pin position, we use a 4.5 mm sleeve and then inserted our 6 mm orthofix pins, and the second pin was inserted with the help of the real external fixator by using the third or the fourth slot. And the third and the fourth pins were inserted accordingly using the help of the fixator and using it as a guide for the third and the fourth pin. And the osteotomy was an oblique osteotomy from the medial side below the level of the tibial tuberosity and towards the level of the fibula head, and the osteotomy correction decided was done pre-op plan, so which is coming to later. And this is the in-shot photo and shows the after doing the osteotomy it was taken care to avoid a fracture of the lateral cortex. We did a fracture of the medial and posterior cortex, and the periosteum was closed, and this is the X-ray. The post-operative protocol include mobilization of the knee, immediate post-op by giving a touchdown weight bearing, and arm of 30-degree minimum was given, and quadriceps strengthening was done. And day 2 itself, we educated the patient regarding the intract cleaning. And this is from day 8 itself, we started distraction about 0.25 or quarter turns every 6 hours, about 1 mm per day. And the full weight bearing exercise were taken from second week onwards, and we assess the alignment again, and if the required correction, and then this is the beauty of the right external fixator, we could do adjustment even in the post-op period. If the required if the correction was too much or too little, we can adjust accordingly based on the exercise. And once the bone was healed, we remove the external fixator. Usually it took about 4 months, and we took around 40 patients for our study. And majority, 50% of them belong to the age group of 41 to 50 years. Majority of them are knees, and interestingly, our cases, majority of them were females. And around 55% of the people around had a 6 to 10 degree of varus pre-operatively, and we corrected to around 4. Majority had a correction of around 4 degree valgus post-operatively. And the knee scorings were also 75% had a good outcome post-operatively. The scores we used were KSS, the knee KSS score and KWS score, and KSS score, the knee severity score, 75% excellent outcome, 75 patients had an excellent outcome, and 84% had an adequate correction. The complications expected were pin tract infection and hinge fracture. Only we had 3 cases of pin tract infection. This is the case. The patient had a deformity, and these are the pre-op X-rays, all the X-rays mentioned previously. These are the angles we planning was done according to the Miniachi method, and what we had planned is around 16 degree correction. And this was the post-op X-ray of the patient. And after adequate valgus correction, this is the final X-rays. And this is the post-operative, immediate post-operative. The patient was mobilized after the planning of distraction. This is after 2 weeks after removal. So our plan was to do this and the outcome was around 75% patients had a good reliable outcome. Majority of the patients were clinically satisfied.
Good work, and I want to ask you, and do you perform the alignment check before every patient? Because they are not young. It is for young patients.
Yes, sir. Relatively, our sample size included patients less than 65, but it is around 30 to 60 years, majority of the patients.
Okay. So the color is different.
Yes, sir.
It's not only in the joint. Sometimes it's in outside. So if it is suitable for acute, it should be evaluated.
Yeah.
I hope you got the question. Did you do a frontal plane planning?
Yes, sir.
Did you do the malalignment test? And Cora was tibia in all 40 cases?
No, sir. We asked selected cases because in the all the deformities were in the tibia itself.
So he says all deformities were in the tibia, which is somewhat hard to believe because it can be anywhere.
The last case, you have shown the color is not in joint, but you correct it just in acute way.
You should be very careful, right? What you are saying.
The GOA is at different level, and osteotomy at different level. Hinge is at different level. Then there will be no mechanical axis alignment. So that post-operative you have not, and post-operative evaluation of the angles you have not done. That is also.
I also have some concerns. So when you say that the pins were parallel to the joint, they did not look really parallel. You are showing an image where you are saying that the proximal pins were parallel to the joint. But I can see on the screen they are not parallel. Whereas they should have been parallel. Yes.
And one more thing, in starting itself, you told that you are doing HTO to postpone TKR. How far is it?
That is a defeatist attitude. So you are already acknowledging that it will not work.
Yeah.
Yes.
Because we have been doing high tibial osteotomy 90 years, 92 years also. So that statement
mentioned right, generally surgeons are preferring advising like that only. So that is why they are not
don't talk
for
about
the
general. You are a surgeon. You are not a general surgeon, general orthopedic. You are a surgeon. Because so many articles are there. Even 90, 100 years also they are doing high tibial osteotomy. 100 years age patient.
On the contrary, arthroplasty surgeons don't like people to do the HTO because they say it messes up their procedure. So there is no end to this debate. But please stick to the thing, right? So HTO for osteoarthritis. Don't talk of TKR and all that stuff. Okay, thank you.
My name is Dr. Alden from KSND Hospital, Mangalore. I'm a junior resident. My presentation today is a segmental non-union and varus collapse of the tibia with an intact fibula post and IML nailing with Elizaro, which is a case study. So, introduction of closed segmental fracture of tibia are treated usually successfully with an intramedullary nail fixation. However, these fractures are inherently prone to more soft tissue damage and can cause a whole host of such complications such as delayed union, malunion, infection and implant failure. And an intact fibula also can help and assist in resisting the compression at the fracture site and can cause delayed union. So my case report is a 40-year-old male, a painter by occupation with no previously known comorbidities, an RTA previous 1 year back previous to the presentation to our hospital. He had suffered a segmental tibia fracture, underwent IML nailing at outside hospital and presented to us with a varus deformity and a limp. So these were his old X-rays. This is a 6-month post-op showing the comminuted proximal tibia fragment and a wedge fragment at the distal aspect of the tibia. He had undergone an IML nailing, and the 7th month he had underwent a dynamization, and you can see the onset of collapse of the proximal tibia fragment and a delayed union at the distal tibia fragment. This is the 8th month where the varus collapse is again progressing and there is no progression of union at the distal fragment. So at presentation, this is 1 year post his procedure. He had presented to us with a proximal varus malalignment and a distal non-union of the tibia with an IML nail in situ. So we established the CORA initially and at the proximal tibia fragment and planned for the Elizaro fixator with the proximal 2 rings and 1 ring at the fractured segment and 2 rings at the distal fracture at the distal tibia. So this is the immediate post-op X-ray. We applied the Elizaro fixator and the distraction was conducted at the 2nd and the 3rd ring to correct the varus malalignment, and the 3rd and 4th ring compression was initialized post the surgery. Also in this surgery, we had done the fibulectomy so as to aid compression at the distal fracture site. This is 45 days post-operatively, post-distractive osteogenesis. You can see the alignment being corrected at the proximal tibia site. And this is 9-month post-operative callus being formed at the proximal tibia site as well as the distal tibia site. RUS score of 10 at the proximal site and distal having a 9. Now, this is a follow-up of 12th month. He had undergone the fixator removal at 9th month and he was weight bearing normally. Went back to his usual activities and was happy post-operatively, so much so that he underwent another fall at his workplace, showing and a fractured the distal fragment fracture at the tibial site. This is the 4th month post the removal of fixator, which is the 2nd onset of the trauma. And he had underwent a 2nd IML nailing, but this time it was easier to insert the nail as the varus alignment was corrected previously. This is 6 months post nailing of well-united tibia, proximal and distal tibia fracture. So an intact fibula in such cases in a segmental fracture can hamper and resist compression at the tibial fracture site, and such thing has to be looked at. The severe soft tissue injury in such segmental fractures is always present, and we have to provide a well stabilized structural and biological environment so as to aid in fracture healing, and that is well provided by Ilizarov fixator. So post-traumatic shortening and rotational or angular malalignment can be corrected any time during the fracture healing period. Another advantage of such Ilizarov technique, and rapid fracture healing is possible, and external fixation time can also be decreased to improve the patient tolerance. So in conclusion, the Ilizarov fixation is a good surgical technique in handling complications of segmental fractures such as non-union and malunion. These are my references. Thank you.
Why do you think he had a fracture?
So the first time?
No, the second time. Of course, first time
So
he had an
he had
accident.
a clear history of falls post
What fall?
the fall from height. He's a painter by occupation.
Okay.
So that was a clear history of
He fell from height again.
Yes, sir.
It
Yeah,
looked like he
from-
fractured from the second side or the distal end of that segmental fracture, isn't it?
Yes, sir. Yes, sir.
So you also have to consider that some of the things that look united are actually not united, or it may not be structurally very sound. So it is a good practice if you can, when you achieve union, to put in a nail which acts as a splint, or give them an external splint for a prolonged period of time. Okay. So when we talk about time in the frame, it is important for primary limb lengthening and all. When you have a complicated situation already, where you are looking at a sort of salvage surgery, you should not be very worried about the time in the fixator. On the contrary, you can keep them more or brace them more to avoid such complications. Okay. Otherwise, it's a very presented case. Thank you.
How it has united radiologically?
So for the tibia, there is a rust score, sir, which takes into 4 cortices in the AP view as well as in the lateral view. So it's a scoring from below 4, it is definitely not united, and a score of 12 and above it shows signs of union. So based on that, we can develop.
What's the normal score? Means normally what we do? 4 cortices.
Yes, sir. So we see the callus formation in the 4 cortices. So we score, each cortex has a score of 4. So 1 being no callus, 2 being callus present, bridging callus, and remodeling.
Tell me the simple thing, on the X-ray, how will you decide? More than three cortex union, you will count as a radiological union.
Yes.
Good afternoon, ladies and gentlemen. My name is Dr. Krishnan, first year resident of Department of Orthopedics and Beams under the leadership of Sadish Nesiri sir. I am going to present a topic on neovascularization by bone widening technique using Ilizarov fixation. As everyone knows, TA or Bridges disease is a progressive inflammatory reaction in the arterial wall with the involvement of neighboring vein and nerve terminating in thrombosis of the artery, which is commonly found in male smokers in the age of 20 to 40 years of age. In India, it is 45 to 63%, but still the treatment is here and there, and no definitive treatment is found. The Bridges disease is essentially clinically diagnosed, but now some diagnostic tools like Doppler, ultrasound, angiogram, which is a gold standard, and angiogram of the upper and lower extremities, MRI, PSA, histopath can be used. The mainstay of treatment is actually you should stop smoking, even if some people just can't quit smoking. Even if their limbs are mutilated, they'll keep on smoking, and this fails the treatment. How does Ilizarov work in Bridges disease? It works in the principles of bone widening and longitudinal by using longitudinal osteotomy. This longitudinal osteotomy will cause a regeneration in the bone fragment and the distal areas. The corticotomy of the tibia or ulna with the distraction causes neohistogenesis, neovascularization, increase in collateral circulation in the distal limb, which according to Professor Ilizarov, it is 2.5 to 3 times in the blood increase in the blood supply. The technique involves longitudinal osteotomy with 5 mm osteotome, a subcutaneous surface at the subcutaneous surface of the ulna of tibia, which about 12 to 15 centimeter long osteotomy for tibia, and the delay of distraction to 7 to 10 days are kept for the healing of the tissues. The weight will be at the range of 0.25 millimeter twice daily, and the amount of distraction amount to 2 to 2.5 centimeter. Here is the technique in which skin incisions are made on the anteromedial surface of the posterior proximal tibia. Multiple drill holes made 7 to 10 centimeter, and the drill holes are connected with osteotome, and osteotomy site is opened up. A traumatic corticotomy where the periosteum integrity is preserved, opening of the osteotomy is confirmed under the CM. The K-wire is, then we are using the K-wire technique, cross K-wiring technique, in which the K-wire is purchased on the medial cortex and goes into the middle cavity, but doesn't pierce the lateral cortex. Two sets of K-wires are used, which or in angulation, the vector will be in horizontal direction, helping the distraction. The material and methods used are 25 patients of age 18 to 60 years of age are operated between 2012 to 2024, followed up from 6 months to 4 years. 80 patients were TAO patients, in which 14 had popliteal artery block, 1 patient had block up to external iliac artery, 1 patient to superficial femoral artery, 2 patients upper limb. 4 multiple patients of multiple discharging signs were there, and 3 of non-healing ulcers were also there. The claudication distance in TAO is less than 100 meter in 17 patients, up to 200 in 1 patient. The severe night pain was found in 17 patients. 16 patients had gangrene of toe, 2 patients had gangrene of index finger of right hand. Coming to the Elizarov for lower limb, the gangrene of right, a 42-year-old gentleman, bus driver was presented in the OPD, who is a chronic smoker since 20 years. And the Elizarov applied with longitudinal osteotomy of right tibia, and the 6 month postoperative photo is this. Then Elizarov for TA of upper limb is presented here with gangrene of the left index finger, in which the same principles of the principles earlier said were used. In spite of, and here we are using 6 to 8 centimeter long osteotomy for ulna, and not the 10 to 12 centimeter which was used in tibia. This is a postoperative photo. This is a distraction photo of the osteotomy site. This is a 4 months postoperative photo, in which you can clearly see the gangrenous limb cannot be saved and it was amputated, and the other fingers were showing 95% SpO2. The result in the in-house hospitalization was for about 10 to 15 days, and the apparatus was kept to 2.5 to 3 months. Pain relief was gradual. In 70 patients, after 2 weeks, the pain relief was dramatic, and prolonged pain relief was assessed by vascular. Claudication distance improved to 5 kilometers in 16 patients. Average time of consolidation was 2.5 to 3 months. 16 patients, gangrene did not spread above. BK amputation was done to 2 patients. Excellent result was seen in 16 patients, and poor result in 2 patients. The same principles were used in non-healing ulcers. 25-year-old male patient with non-healing ulcers with the same principles, and the wound size is decreased during distraction. This is the 3 months photo after the fine removal, and same principles were used in multiple sinuses also, in which after the intervention the sinus started healing. Discussion: the law of tension stress comes into play in this study or in this method, in which stability of fixation, atraumatic corticotomy, rate and rhythm of distraction, indirect function, and indirect vascularity plays the role. Then the advantages of Elizarov are there. In our technique, plain crosswire is used. Conclusion: Elizarov fixator for TAO is a simple, safe, inexpensive, and reliable method, and with subsequent higher level amputation. Thank you. Have a nice day.
Okay, it's good work. And how many cases have you done? How many cases have you done for the TAO?
So for TAO, we conducted about 18 patients, out of which 16 were having excellent result and 2 were having poor results.
Have you started with the CTA or DSA such methods to evaluate the blood vessels?
We haven't done DSA and MRI because we are working in a government setup with no facility of doing DSA. So we were confirming it with the Doppler ultrasound and clinical findings.
So it's very important to evaluate the blood vessels because for the skin temperatures or for the soft tissue temperatures, it is not stable. And if it is stay in a cold place, stay in a warm place, hot place, it's different. So for the wound, even without this technique, some wound can heal. So this is the problem, is that you don't have the evidence. You can show my technique is effective. Okay.
Yes. Thanks.
Okay, you don't need very fancy equipment if you want to measure. So you saw the pulse oximeter. You can put it pre-operatively. Then you can show the difference in the pre-op and post-op. You can also do a Doppler ultrasound, which is available everywhere. And then you can use some quantitative Doppler parameters.
Yes, sir. We use Doppler actually.
But then you have to show us comparison in the pre-op. Or you can also do an ankle brachial index, ABI. That is also very easy. So this is excellent work, of course.
Yes.
But from a research viewpoint, you should add also some hard outcome measures that you can show.
Yes.
And also well presented.
Thanks. Thanks. Thanks.
Okay, next.
Good afternoon, respected faculties, my dear colleagues. Dr. Rafael from Calicut Medical College, and discussing the topic outcomes of proximal osteotomy and MCO and greetings from the Department of Orthopedics, Calicut Medical College. Prevalence of NEO in elderly in India is between 30 to 64%. MCOF is 50% of the NEO of Indian population, which means that 50% of Indian population have varicose. Available treatment methods are realignment surgeries, which is the knee preservation using open wedge or HTO, closed wedge HTO, using both Ilizero and Orthofix, TCB and PFO. The replacement surgeries include UKI, unique condyle knee replacement, and total knee replacements. So the reason for the study is all realignment surgeries except PFO requires technically more acumen, need implants for fixation, constant follow-up, implant and surgery related complications. So the study we use a simple procedure called proximal fibular osteotomy to treat MCOA. It's a safe, simple and effective procedure that's an alternative to other treatment options for MCOA. So original rationale, Yang et al. In 2014 suggested that fibulectomy results in a decrease in the medial compartment pressure and increase in the lateral compartment pressure. So they surveyed the joint reaction forces across cadaveric knees after fibulectomy. So following this, they suggested that performing fibulectomy can have protective effect by reducing the pressure over the knee joint. So what's the concept is that it's known as the concept of non-uniform settlement. So the bone density of the fibula was found to be higher than the medial tibial plateau. So as osteoporosis settles in, the support of the fibula by the lateral tibial plateau does not allow the lateral side to settle. So that creates a varus deformity, and this has been called the non-uniform settlement. So in PFO, when the support of fibula is removed, the lateral side settles down. So loading the proximity evenly and leading to correction of the deformity in a varus knee, thereby relieving symptoms and reducing the deformity. So the materials we use, study design was a pre and post-op intervention prospective study. Study settings were patients with MCOA admitted to the Department of Orthopedics, Government College Calicut. Study duration was 1 year from the time of epithelial clearance and sample size was 25. The inclusion age less than 60 years, patients with moderate severe symptomatic MCOA of the knee with a KL grade 2 or 3, knee mass less than 20 degrees were willing for surgical management, BMI less than 30, full arm of the knee and patient with moderate daily activities. Exclusion include infection of the knee joint, either current or past, post-traumatic knee OA, inflammatory joint disease, DCOA of the knee, or history of previous operations or fractures. So technique under spinal anesthesia, patients were placed in the supine position with the lower limb tonic inflated and the fibula head is marked, and lateral incision was made 7 to 8 centimeters was made at the center 8 to 9 centimeter below the head of the fibula. The fascia was incised in line with the septum between the peroneus and the soleus. The muscles separated and the fibula is exposed. A 1 centimeter section of the fibula was removed 8 to 9 centimeter below the head with the use of a saw or osteotope. So the fascia then sutured separately after the incision has been irrigated large volume saline, and post-operative patients are ambulated as soon as pain can tolerate. So data analysis, the patients with MCOA underwent PFO were followed up at 2nd week, 4th week, 12th week and 24th week, and as outcomes were assessed with NACE society and pool score. So analysis, sex were almost 100% of females, age group between 55 to 60 years, mean age of 6.79 and standard deviation of age of 4.79. So post-op results, this is the bar chart showing that there is a gradual improvement as the weeks progressed in both the NACE society and pool score. This is a line diagram depicting the same, showing an increase in the scores of the patients. So once we did the study, there was a significant study value for both the NACE society and the pool score, which is less than 0.05. So case example of the same showing the variation in the HK and GLC. You can see this difference in both pre-op and post-op. This is another example showing the same, where there's a difference in the hip knee angle and joint line convergence angle. The second is another case example of the same for another patient, showing the variation of the pre and post-op. So advantages: this is cost-effective, technically less demanding, no implants needed, small incision, lesser blood loss, early mobilization, and short-term post-op hospital stay. Complications: we encountered CPN palsy, EHL weakness, and SPN injury. So limitations of the study was shorter, 32 weeks, and a lesser sample size. So coming to the conclusion, findings revealed a significant improvement in the activity levels and pain scores after surgery. The patient reported NACE society and KOO score fall under the category of good knee status and function, and PFO gives good results in middle compartment OA, keeping in mind that the patient is proper patient selection. Thank you.
How many patients had complications?
So one patient had EHM weakness and one patient had CPAP palsy. Total 2 patients.
2 out of 20.
25.
2 out of 25. Okay. And by how much did the score improve? So I didn't see any comparison there. So what is the difference between the pre-operative and the post-operative score?
So we assessed weekly, like 2-week follow-up.
Yeah, but what is the magnitude of change?
It's gradual, sir.
You don't understand. So if the pre-operative score was 20, post-operative was 40, something like that. What was the?
Yeah, so like initial weeks, like if you look at the span of 1 month, it was less. But as the weeks progressed, there was much better improvement.
Much better is not the way to present in the research. You should show some statistics. Do you know what is an MCID? It's a minimum clinically important difference. Okay, so if I say that pain improved from, or let us say the VAS score improved, it was 8 earlier and then it became 6 later, and the statistics is significant, but clinically it may not be significant. So what is that magnitude of score which is clinically significant? Right? One is statistical significant, P is less than 0.05. But in all of these things, you should also look at a clinical significance. And for all these scores, the MCID values have been reported. And whenever you want to say that this procedure is good in terms of pain or in terms of function, then you should be reporting the MCID values, including the pre-operative and the post-operative and the change between them. It is a must. And when you say that there are complications, just report in numbers what percentage of the people had complications. Okay?
Have you did a planning for all the patients?
Yes, sir. The patient selection was done based on
Planning, frontal planning, sagittal planning, everything was done.
Yes, sir. We selected patients with less than grade 2
Grade 2. For osteoarthritis, what is the standard? How will you proceed? Suppose your grandmother has osteoarthritis. Will you do, or if people are osteoarthritis?
It depends on the grade of OA.
Then she will kick you.
What if there is a virus deformity? Maybe there is maybe I have a lot of virus, so there would only be a.
So if there is virus deformity, then that is to for TK.
Could I tell you a story that in China, Professor Zhang, and the same family name as me, is very famous. He had this operation, the fibulotomy, for several years, has a large amount of cases, but long-term follow-up result is poor. It's not good. You can.
Height will also come. Then you will come to know.
Thanks. Hyderabad, under Dr. Raju Srinivasan. So I'm here to share our experiences in TPO lengthening. So coming to the introduction, lengthening by user works on the principle of distraction and stability. So gradual traction on any tissue creates stresses that can stimulate and maintain the regeneration and active growth of certain tissue structures based on the law of tension stresses. And lengthening done in patients with the limb length discrepancies around 5 centimeters. Coming to the aims and objectives of the study, this is to evaluate the complications associated with TPO lengthening done by user and patients with the limb. Inclusion criteria: patients around above 86 years old, with severe gap non-union, infected non-union, and no consent for surgery, and who are very much motivated for release around. And exclusion criteria: people more than 65 years with poor compliance. Coming to methodology, 100 consecutive patients who had episode and which 20 consecutive patients with significant elderly who require limb lengthening are taken into the study, and evaluation done from preoperative pulmonary X-rays to the preoperative preparation of Elizarov frame, and the stages surgery was done by deployment, acute talking, and Elizarov frame application, followed by corticotomy on day 3 to day 10, and a gradual distraction done at a rate of 1 ml. Post-operative management: all the patients had RM exercises and the clinical and post-operative graphs by day 2. And we trained post-operative training. Patients should be walking with heel strap. If they walk on equinus deformity, the weight-bearing exercise is at the proximal tibia, which can lead to poor compression at the fracture ends, and the poor regenerate and can lead to a delayed union or even non-union. Coming to the results, out of 20 cases, 2 had fibular complications, 2 had wide breakage, and 5 patients had inside infection, and 3 patients had early frame removal due to pure compliance from the patient party. Coming to the discussion, in condition with TP bone loss, non-unions and infected non-union, we can either go with talking, followed by lengthening or a bone transfer. Whatever the surgery, the goals of the surgery is to equalize the limb length discrepancy in the shortest time with the minimal pain, with the smallest and limited finances, with a limited weight. We went for a staged procedure because the risk of vascular injury is less, and we add a basic Elizarov frame initially, and which is very much reasonably less painful compared to a corticotomy and Elizarov done at a single stage. Coming to acute talking followed by lengthening, here we open the fracture site, freshen the margins, and dock the fracture ends and apply Elizarov, etc. So we make sure that there is a 360 degrees of bone-to-bone contact and an axial rings along with alignment and compression of the fracture site. This ensures that the 360 degrees axial loading at the fracture site. Post-surgery, when patient is comfortable, we do a corticotomy at the proximal end and then lengthen the tibia from day 3 to day 10. So there is a compression at the fracture site along with the lengthening occurring at the proximal end. Complications with wire breakage, inside infection, early removal of Elizarov, poor patient compliance, skin breakage, nerve injuries, muscle contracture, and refracture. Complications of acute talking followed by lengthening. We do have bone closure issues, so never give a straight incision, always go for a lazy S incision. Acute neurovascular compromise, development of equinus deformity, fibular complications, as you can see, the fibula receding down, bone regenerate, premature consolidation, delayed union. How do we prevent the vascular compromise? Never dissect the vessel, let it be in the soft tissue, and make sure that you check the pulses and adequate limb elevation post-operatively to prevent swelling. So complication used as part of the treatment. In the preoperative X-rays, you can see a dilating fibula. She is a 12 years female with post-septic sequelae with 20 centimeters shortening. Coming to the bone transport, we can go for a bone transport. We do adequate debridement till we see a paprika sign. Then after all the laboratory and clinical investigations showed to be infection free, we go for a gradual distraction done at 1 ml per day and 4 parts. Acute talking versus lengthening and versus bone transport. Bone transport, it may be a double procedure. You can have an alignment issues if the transport length is more. Even though the risk of vascular injury and the bone closure issues are less, patient will have a poor visual confidence on seeing the radiograph. In acute talking by followed by lengthening, patient has a very good visual confidence that he can see the radiograph that my bone is aligned. In bone transport, you need to consult preoperatively that it takes time for your bone to have a contact. This is a case of 45-year-old male with a history of RTA with a significant bone loss. we did acute docking, then a corticotomy, and a sequential lengthening. Initially developed a poor region rate, but 9 years follow-up is doing decently good. Case 2, this is 25 years old male with segmental non-union. He had soft tissue issues, so we went for an acute docking. This is follow-up. This is case 3, where you can see a distal third non-union of the tibia, both bone. Then we had acutely docked, and then this is the 4 years follow. These are my references. Thank you.
Lot of written material. In one slide, maximum 4 to 5 lines should be there. Almost it is more than 10 lines. Really difficult for us to see.
Last slide actually healed in procurvatum deformity. So it's good. Are you showing that as a complication or as a good outcome?
Because the patient had still LLD post-operatively also, but she achieved a union and she was doing comfortably with her daily routine. So she was like, I'm okay with whatever I have. She was not, she doesn't want to go for another surgery.
Patients are like small children sometimes. They don't know what they want. It is also our moral responsibility, which doesn't mean that you should make every problem a big problem. But problems like this, sometimes you need to step in and say that even though you may not be aware, the patient may not be aware, but it is our also responsibility to counsel them. Okay. Well presented. Any comments? Okay. Thank you. Next speaker, please. Thank you.
My name is Dr. V.B. Hemant Kalyan. I am from Department of Orthopedics, Nizam's Institute, Telangana. Acknowledgement, Dr. Raju Srinivas Iyengar sir and Professor Dr. K.C. Srikanth sir. So, infected non-union of femur, both the mechanical as well as the biological factors play an important role in halting the healing process resulting in the non-union. Going by the literature, the rate of infection is around 3 to 13%, and with only 66% healing as intended. So, coming to the factors that cause the non-union, so there are injury related, such as the mechanism of injury, the amount of soft tissue damage. Coming to the metabolic factors as well as the implantation factors. Implantation factors, these plate length, working length, the screw size, the fixation technique, all of these play an important role in resulting in the non-union. So coming to the challenges in that of non-union of femur, the radiological challenges, the bony challenges are avascular bone, there's loss of bone stock, there's multi-drug resistant polymicrobial infection, there's scar tissue, multiple times operated, and that in turn is resulted in depletion of graft donocytes. The performance of Ilizaro varies greatly from that of tibia in that there's the conical circumference is larger circumference of the thigh, there's difficulty in placement, as well as the psychological stress that has to be that is placed on the patient, as well as the personal hygiene. So the patient factors, most of the patients that present to us with infected non-union, they present late. There is already the amount of variable joint stiffness at presentation, and there is the major damage to blood vessels and multiple previous surgeries, in turn impeding the psychological state of the patient. So coming to the apparatus construction is paramount in dealing with non-union of femur. So the apparatus construction, there are multiple variations, and the surgeon has to be aware of them both preoperatively and intraoperatively. So the proximal construct cataclysmic modification that includes the proximal shank spins, that has to be meticulously placed. There can be introduction of the dummy ring or the intermediate ring. And coming to the surgical technique, dealing with the removal of infected necrosed tissue along with augmentation with propitious graft or autogenous graft, and also keeping in mind that docking along with intermedullary reaming has to be performed while doing the surgery. So these are the three cornerstones: excision of devitalized tissue, emphasis on nursing and local tissue care, and compression and bone grafting. So post-operative care, functional loading along with shoe rise, good counseling from the physiotherapist, systemic antibiotics, and in the follow-up period, the patient has to be periodically checked up. The concerns, even with adequate preoperative counseling, is the psychological and physical stress on the patient, the bulkiness of the fixator. There is always a race between weight of the fixator versus the stability of the fixator, and the surgeon has to meticulously plan and counsel the patient preoperatively and postoperatively. So, the materials and methods: infected non-union femur cases at a single center. We have taken 10 retrospective cases that have included the inclusion criteria. So, the inclusion criteria: non-union femur, minimum follow-up of 6 months until radiological union has been attained and completely free from the armamentarium. Exclusion criteria: very obese, inside side, non-compliant patient and less than 6 months follow-up. So the outcomes are measured from the rate of union, the NIRM, the complications phase, ASAMI score, as well as the lower limb functional scale. So this is the ASAMI score, and this is lower limb, lower extremity functional scale. It is the maximum score is 80. So coming to the discussion, infected non-union of femur can be treated with meticulous placement of hybrid Elizero fixator, adequate functional loading and counseling, and radiological attainment. So these are the 10 retrospective cases with approximately radiological union being attained at 5 months, and the functional loading started at day 2 in most of the cases. We had to face few complications with fused knee in one case and stiff knee in one more case. So these are the cases. One 20-year-old male with IL nail institute managed by Elizero. This is his latest follower. Having a good knee range, he is able to perform his daily activities. This is a patient operated twice by XFIX elsewhere, and he was managed by Elizero following the previous set principles. The knee range was okay, acceptable, but patient is able to bear weight, is free from armamentarium, and infected plate institute managed by Elizero, and now he is having a good knee range and performing his daily activities. This is a 18-year-old child with severe osteopenia, gap non-union, atrophic gap non-union managed by Elizero. After union, the patient was done with corticotomy and limb lengthening, and these are final outcome. So conclusion: patient counseling and compliance is paramount in role of femur Elizero. Meticulous planning both preoperatively and post-op.
Good afternoon, sir. Myself, Dr. Panikumar, second year postgraduate from SIMS and RC Bangalore, and my guide, Dr. Harshad Emsha, sir. Thanks to my guide for all his support every time. And my paper, that is hybrid external fixators, how to use Elizero combined with other external fixators. That's our experience in these cases. So the use of circular Elizero frame with transosseous wire considered as Elizero fixation, whereas the use of half pins with transosseous wire is considered as hybrid Elizero fixation. Here, use of other external fixators along with Elizero external fixator in complex trauma and also in deformity corrections is being presented. So sample size, there is 2 cases of GA type 3B compound tibia fractures, and 2 cases of Schatzker's type 6 tibial condyle fractures, 2 cases of pylon fractures, 2 cases of proximal humerus fractures treated with Elizero, and 2 cases of clanging of toes and 2 cases of CTEV we have taken, total 12 cases. All the cases are followed for a period of 36 months. So coming to case 1, so he is a male doctor of age 25 years with RTA run over by tractor type with compound type tibia, type 3B with bone loss. So this is his initial X-ray when he came. So initially skin flap was done with along with external fixator view. It was good, skin flap it was fine. Later on, that is this is the X-ray. Later on, that is after 2 weeks, there was minimal discharge. The wound was clean, and he's on antibiotics and AOX fixator. Then Elizero application was done. So after 11 months, of application of the Elizaro. And after 2 years and 8 months, and the clinical results of this case, there is no shortening, no deformity, no infection, and a log has been attained and fracture union was seen. Coming to case 2, where it is a Shaxter type 6 tibial plateau fracture. Here, the Elizaro frame with AO X-fix rod has been applied and it was good, patient was happy, union was achieved. Later, after removal of CC screws was put and he attained a knee flexion of 110 degrees and entire knee ROM achieved and patient was happy with his functional outcome. And coming to case 3, where the proximal humerus fracture, where Elizaro frame is combined with AO X-fix rod to attain stability, was being used in this case, and this is another big, and a good stability was achieved in this case, and functional outcome was also fine. Whereas coming to case 4, whereas in case of CTUV, here also Elizaro has been combined with just external fixator. So he's a child and the functional outcome was good with minimally invasive correction, deformity correction attained with very minimal complications as just combined with Elizaro. And this is final clinical picture. And last case, that is the clag of dose. Here also the same, the just with where the low volume just was combined with little bit high volume of Elizaro, but it was fine and he was happy. Coming to the results, hybrid Elizaro fixation in complex trauma and deformity correction becomes easier to use treated patients with Elizaro. But certain situations where Elizaro components are many and cumbersome, the components of other fixators will be useful. Coming to the conclusion, use of other external fixator which are cost effective along with Elizaro external fixators become easier to treat the patients by Elizaro in case of complex trauma and deformity corrections. The components of other fixators can be combined successfully with Elizaro external fixator components. Some of them are simplified fixators as in avotubular, X-fix, similar like escular, etc. Even simple just or UMEX external fixators can be used along with these Elizaro external fixators, particularly when digits of hands and foot are to be fixed. Sometimes these components as we just turn out to be cost effective also if we attain a good stability. So thank you.
It is all messed up actually. We cannot take any conclusion from your thing because in first case you showed initially AO fixator applied, then removed, then Elizaro was applied, and second case you showed hybrid frame, and then subsequently you removed AO fixator and converted into Elizaro, and later you showed CTV where only Elizaro was seen, and last for toe correction you used only just that bar. That is not necessary only.
Sir, in first case, instead of
most of the your photos also quality is very bad. You cannot see anything properly. So can't conclude anything with your.
Sir, in first case, instead of using Elizaro from the first we have used the AO X-fix, and in second and third cases, instead of using complete Elizaro, if we are getting the same stability by using combination of X-fix.
Just observational study. That's all. Can't conclude anything.
If we are getting the same stability with Elizaro, with combining the simple external fixator,
stability of Elizaro with AO fixator only. In hybrid also, you showed one proximal tibia. AO fixator with external. You cannot make the patient walk immediately. It's of no use. People who doesn't know how to put Elizaro do all such types of stunts. That's all.
I haven't heard of that. I think it counts to say who doesn't know or I don't know. He is the student who is presented as a postgraduate. A little bit of work on mine.
The idea here
is to present that. Hello. Yes.
Yeah. The idea here is to present Elizaro components which can be combined and used with this one. Can you go back to the this one? He said that one you showed completely Elizaro, one you showed completely just. I think it's wrong. Nesri has not observed properly. If you can go back, you can see that I have used Elizaro on the tibia and foot and just onto the toes and connected it to the fixator. Not many people are doing like that. If you want to connect with Elizaro, it is not impossible. The whole world is doing fixing with only Elizaro everything. But slowly here and there, when we don't have components in place, when we don't have certain things, now and then, when this is of course very common, all of you know this, and we know that it has disadvantages. They cannot walk this, that, but then there are people who are in the learning stage, they want to do these things. See that? All the toes have been fixed with wires and with just fixation. You get it? It is not Elizaro there. And the results are going to be same. The object of presenting this is to see that you can combine Elizaro fixator with all the other parts. The Escalab clamps, the JES, the UMAX and AO fixator. You can, if you know how to do it, you can. And you have a few advantages there. It is nothing great about presenting this paper and the results of this one. We can get results using Elizaro, you can get results using LRO, you can get results using combined things and all that. The objective of this paper is to prove that you can use other fixator components along with it. Thank you.
Thank you, sir. Next.
My topic is limb reconstruction post tumor excision of distal tibia using Elizaro fixator. It's a case study done in Sri Ramchandra Institute, Chennai. Introduction: giant cell tumor of bone is a common benign tumor that is locally invasive and has the potential to metastasize. It is characterized by high local recurrence rates up to 65%. Giant cell tumor most commonly affects the proximal tibia, distal femur and distal radius. Foot and ankle giant cell tumors account for less than 10% of all cases of GCT of bone, with the distal tibia being the most common among them. Giant cell tumor of distal tibia has been found to have an association with pulmonary metastasis in larger than usual proportion. Following is a case report of a middle-aged gentleman diagnosed with the same, managed by excision of the mass and reconstruction using Elizaro technique. A few on a literature review, GCT of distal tibia was found to be very rare. Foot and ankle GCT was rare, and among those, distal tibia GCTs was found to be more common. History: a 36-year-old gentleman presented with pain and swelling over the right ankle for a duration of 2 months. Swelling was initially small and progressively increased in size. Pain was associated with swelling dull and diffuse in nature. History of loss of appetite, loss of weight of about 8 kg over the past 6 months present. There was no other constitutional symptoms, no history of any trauma or fall. On examination, localized swelling of size 5 by 3 cm over the medial aspect of the ankle. Skin was adherent to the swelling. No secondary changes of the skin were present. Swelling was variable in consistency. Edges were ill-defined. A range of movements, inversion and inversion were restricted terminal. There was no regional lymphadenopathy. This is a clinical picture. This is a presenting X-ray of the patient. An MRI scan was done. MRI was suggestive of giant cell tumor of the distal tibia. There was no involvement of the ankle joint. An ultrasound guided biopsy of the lesion was done, which also showed features suggestive of giant cell tumor with an aneurysmal bone system. The mainstay of treatment for GCT is surgery. Surgical options include curettage and cement packing, curettage with bone grafting, and resection and reconstruction. Based on the literature review we decided on doing a resection and reconstruction. So the patient underwent right distal tibia tumor excision and reconstruction with the Elizaro ring fixator along with the surgical operating. So pre-operative planning, the lesion was found to be 7.2 centimeters long. So we made a Elizaro construct planning based on that.
This was the intro of images. En bloc excision was done along with the skin. The excised part was found to be around 10 centimeters in length. That much bone loss was there. This is the construct we made. Histopathology also revealed to be GCT with aneurysmal bone cyst. Post-operatively, after 1 week, distraction was started, and by around 6 months, length was attained. 1 month post-op, he developed a wound over the operated area, and it was treated with antibiotics and regular dressings. And at 6 months, he was planned for docking, so we did a transfibular approach and a tibiotalar arthrodesis was done. The talus was prepared and docking was done. And at 8 months, the construct was removed, and now at 1 year follow-up, patient is having good functional outcome. Patient is walking full weight bearing without any much complaints. Conclusion: there are significant difficulties in managing of a giant cell tumor located in the distal tibia, including factors such as recurrence, cavitatory bone lesions, arthrodesis of joint, and reconstruction during surgery. Giant cell tumors, though benign, may sometimes present as a locally aggressive tumor. A multidisciplinary approach is needed to manage such cases. The distal tibia reconstruction and ankle arthrodesis using Inusaro ring fixator presents as a promising approach for addressing such complex ankle pathologies. It offers several advantages such as customizable fixation, gradual correction, preservation of soft tissue, management of soft tissue complications post-surgery. Despite the technical challenge and prolonged treatment duration, and patient compliance is also needed for a good outcome. These are the references. Thank you. Denosumab in a lower grade.
Why you did not do curettage, denosumab and bone grafting or bone cement? Why you did not do it?
The articles showed that curettage high rate of recurrence was there in distal tibia lesions, so we went for a resection. The literature review showed that resection.
CT was done. CT was done.
CT was done.
Was there any breach?
No cortical breach is there, but the thin margins are there. And the surgical onco team also said since that skin adherents and all were there, it's better to do an en bloc resection. So.
Okay, this is a nice case. I have a couple of comments. First, so your resection, it is like a radical resection, as if we would do it for an osteosarcoma.
Yes.
So you could have resected this. The advantage of doing that is, of course, it decreases the time to bone transport. Yes. And by saving even 2 centimeters, you save nearly 2 months. Right? Yes. So that is one observation. The other observation is that the talus is translated too much posteriorly. Yes. So a mild posterior translation of the talus offloads the midfoot joints, but a too much posterior translation was a bit. So I would have really liked to see your patient walk, because I suppose now their center of gravity is not where.
Yes,
the plumb line will not.
Yes, sir. But the patient is actually comfortable. He's not having much pain.
You should see them walk. There would be some awkwardness at the gait.
Yes, sir.
So whenever you're doing cases like these, don't translate the talus too much posteriorly. It is too much translated posteriorly. Some sort of problems. So I have revised 2 of such cases where the patient's problem was they were falling repeatedly. The mechanical axis in the sagittal plane is not perfect, then they have some trouble on the. Okay. Thank you.
Thank you.